Professor Ironside, before the break, I was asking you some questions about the infectivity levels of blood and blood components in the framework document. And I think I need to go back over one of the questions I asked you, because I think I misspoke in the question I meant to ask you, and I just wanted to check your answer. So could we have back on the screen, please, DHSC 002-0839_003, and could we turn, when it comes up, please, to page 34. And that we have back on the screen table 7.
Yes.
And we were looking at blood components.
Yes.
And having looked back at the transcripts, those that have the transcript at 12:30.25, I asked you a question, and I asked you a question. I said, so for 2 millilitres of whole blood, there are 2 infective doses. And what I meant to ask you, and what I should have asked you, was, so for 1 millilitre of whole blood, there are 2 infective doses. Now, your response to my first question, on the premise that it was per 2 millilitres, was yes. If I asked the question I meant to answer, can I see what your answer is? For 1 millilitre of whole blood, are there 2 infective doses?
Yes, there are 2 IV ID50, exactly. And I should also clarify my explanation of an ID50, because it wasn't very clear either. So an IV, as I said, is intravenous. An ID50 is the dose at which half a group of exposed people would be infected through the intravenous route. So that's it. It's specifically intravenous infectivity. If it was another route, say, inoculation into the brain, that would be intracerebral, and the ID50 for that would be a very different sort of figure. So this is what we're looking at. So it's ID50 intravenous route, and the reason we use ID50 because it allows you to compare levels of infectivity in different components. That's the main purpose of it. So you're comparing infectivity in whole blood plasma using the standard form of presenting the level of infectivity to allow clarity. I hope that's now clear to all of us, including me.
I think it is. I think that just for those who are watching, it may also be helpful if I ask this question, which is, this isn't a measure of the number of defective and therefore infective proteins or prions, is it? It's just a measure of whether at that particular level of dose you begin to get into probability that there will be infectivity from it.
Yes, that's absolutely correct. And in fact, attempts to correlate protein levels with infectivity have not always been very helpful. So this is another reason why the ID50 is used.
Yeah, thank you.
Can we turn then to look at the decision-making in relation to identifying who should actually be notified? And can we start back with your witness statement, please, which is WITN 7034001. And could we go to page 80 of that, please? 80. Thank you. And it's right at the bottom of that page when it comes up at paragraph 2. So you say this: if patients had been exposed to a threshold of 1% or greater potential risk of VCJD over and above the general risk to the UK population, believed to have resulted from dietary exposure to the BSC agent, the panel advised that they should be considered at increased risk, notified of this status, and requested to take public health precautions. This 1% additional risk equates to an exposure of 0.02 infective doses to 50, which is the equivalent level of infection at which public health precautions are implemented for patients exposed to VCJD via surgical instruments. And then if we just go over the page before I ask you the questions, the 1% threshold level is used as a cut-off for implementing public health precautions and is not intended to be a precise measure of an individual patient's risk. So just taking that in stages, you say there that the general UK population is already at a risk of VCJD as a result of primary infection through the oral route. Yeah. Has that been quantified? Do we know what that risk is?
I don't know if it has been quantified. I think it would be extremely difficult to do this, and I'm not aware of any precise figures that have been published on that particular matter. But I think it's just assumed that there is a population risk, and most of the population probably has been exposed to it. But the population exposure will be different depending on dietary differences, age differences, etc. So we're looking at additional risk beyond that.
And you say there that the 1% threshold level of increased risk was chosen, is this right to understand, primarily because that's what had been chosen for patients exposed to VCJD via surgical instruments?
Yeah, it wasn't based entirely on that, but that is certainly the case. And when we were deciding what the cut-off figure would be, there was a whole range of scenarios considered, and it really became down, should we use the very most pessimistic scenario, or one that was still pessimistic but not quite so extreme, if you like. And I think the general view of the panel was they were comfortable with the 1% threshold in terms of implementing public health precautions, and that's one of the reasons, if not the main reason, why it was chosen.
And if we can go back a page to page 80 again, please, Lawrence, just to look then to remind ourselves of what the 1% additional risk equates to. An exposure of 0.02 infective doses. So is it right to understand then that there will be people that have been notified that they are at increased risk of VCJD for public health purposes who will not have received an infective dose?
Well, I think that the 0.02% ID50 is, in this case, I think not necessarily helpful, because the individuals exposed to 1% additional risk, it just depends on the circumstances surrounding the exposure. But some of them, I think it was felt that within that population exposed to the 1% risk, the risk wasn't uniform, and some would be lower than others. And I think that's all I can say about it. Really.
We'll come on to look at a document which may illuminate may illuminate that, or may not.
Thank you.
I don't know. And then turning back, sorry, to page 81, I just want to ask you, back up to top, you make this point. The 1% threshold level is used as a cut-off for implementing public health precautions and is not intended to be a precise measure of an individual patient's risk. So can you just tell us what the difference is between those two?
The 1% threshold level is the cut-off. So above that, there will be various individuals who've been exposed to different types of additional risk and different quantities of infectivity. So as a cut-off measure, it is a cut-off measure for public health action, as it were. It's not a measure of individual patient risk. Trying to calculate that would be very difficult, and it would depend on a whole range of things like the amount of plasma products that individual was exposed to over time. So it's not that. It's a threshold measure for public health action.
And having set the 1% threshold, is it right to understand then that the CJDIP then advised that any surviving recipients of implicated batches of red cell concentrates should be notified because they would have met the 1% threshold, and that's a notification that took place in December 2003?
Yes, I think that's correct. And that's what it says in the.
I think that's what it says in your
next
statement.
Paragraph, yes.
Yeah. Then looking at notification of patients who had received implicated plasma products, can we look at a meeting minute from the CJDIP, which is PHEN 40502? Here we can see a meeting 12th of May 2004, and some of the way down the page is your name as a member and attending that meeting. Can we please turn to page 10? We can see down at 11, paragraph 11 at the bottom there, incidents involving plasma derivatives. Dr. Bone presented the key outcomes of the technical subgroup meeting on the 21st of April, which I believe you attended as well, which for the transcript is DHSC 304206_072, to discuss the results of the work done to date by the HPA and to make recommendations to the panel on the approach to be taken to the notification of recipients of implicated plasma products based on the product risk information collected to date, which included estimates of the infectivity levels in implicated plasma product batches so far notified and the likely number of individual recipients. The following approach was agreed by the panel. Plasma products would be stratified by estimated infectivity as either high, medium or low risk. And if we go over the page, for patients with clotting disorders, haemophilia A and B, von Willebrand's disease and congenital antithrombin 3 deficiency, a single dose of factor VIII, intermediate implicated, factor IX and antithrombin would be sufficient to cross the 1% risk threshold. Public health measures to reduce the risk of infection would be applied to all patients receiving plasma-derived UK-sourced products since 1980, the umbrella approach. Patients would be offered the choice to discover whether they had received an implicated product, and individual risk assessment would be recorded on the UK HCDO haemophilia database for the long-term follow-up of potentially exposed patients. Now, just pausing there, you say in your witness statement that the decision to adopt what's been termed the umbrella approach, in other words, to notify all patients with bleeding disorders that they are at risk of VCJD for public health purposes, irrespective of how much product they've actually received, was at the suggestion of the UK HCDO. Is that right?
Yes, I think that took place at the earlier meeting that you referred to, and I recall also, I think there was a representative from the UK Haemophilia Society at the meeting, and they seemed to agree with this approach also. And I think these were major factors in deciding that we should go ahead on that.
And can you recall the reasons why it was thought that it was appropriate to adopt this umbrella approach?
It was based on the advice from the haemophilia doctors and indeed the patients, and I think the argument was that it might be difficult to try and dissect out what all individual risks were and then which risks should be informed. My view, which I think I mentioned, was that in terms of implementing this, it was seemed to me a large and very complex exercise, and perhaps it should start with those who are at the greatest risk and then work its way down, if you like. I don't know if that was done, but that is my understanding. It felt easier or more appropriate, I should say, to inform everyone than to inform some and not others, because perhaps it was felt that there were others who were not informed would still want to know what their risk was anyway.
So I'll come back to this idea of a notification by stages rather than all in one go.
Yes.
But just on the question of why the umbrella approach, was there a concern, or do you recall whether there was a concern expressed that while a particular individual may not, in May 2004, have themselves crossed the 1% threshold as a result of the amount of product they received, that there were bound to be more notifications in due course because cases of VCJD were coming through and there were bound to be more donors who had donated the plasma pools. And so to avoid multiple notifications, the thinking was, well, let's notify everybody now. Was that, can you recall whether that was part of the thinking?
You're right. I think that was part of the thinking. And I think prior to that meeting, there had been various occasions when VCJD donors had been identified, and that had prompted individual actions, as it were.
So then turning back then to the document we were just looking at, I think we can miss out the primary immunodeficiency syndrome patients and go down to for other groups of patients. If you're just a little bit below where we are now, heading is bullet point for other groups of patients on that document there, for other groups of patients about halfway down. Yep. It says here, multiple doses of implicated intravenous immunoglobulins and albumin products would be sufficient to cross the 1% threshold. So there is a theoretical, well, there is a risk for some patients they could cross the threshold. Patients in less well-defined groups who may have received sufficient implicated product to pass the threshold might be difficult to trace. A feasibility study would be undertaken in relation to this group. However, the notification of first two groups of patients would not be delayed by this work. And then, where possible, an individual risk assessment will be carried out, and patients who had received sufficient product will be asked to take public health precautions. So, so that a rather different approach to this group of patients, is this right? That it's actually deciding, well, on an individual basis, we will decide whether or not you've crossed the 1% threshold, and then we will notify you. Is that right?
Yes, that's correct.
And then lastly, patients who had received minimal risk products, human normal immunoglobulin, anti-D and factor VIII, where the excipient is implicated, would not need to be contacted, since it is unlikely that any patient would have received the very large doses needed to cross the threshold. And then if we go over the page, however, factor VIII recipients would be contacted as part of the umbrella approach for patients with clotting disorders. So that's the umbrella group. For individual risk assessments, the total cumulative dose would be used rather than the annual limiting dose as proposed in the DNV risk assessment. The DNV model assumes regular equal doses of VCJD over several years for clearance of infectivity, but this was considered unlikely to occur in practice. and then SIACA to consider that in the future. And then if we go down to just above Action Secretariat, it says the framework document will be amended to reflect these decisions. The HPA would work with the devolved administrations to ensure the notification took account of the different health organisation structures, and the CMO would be kept informed about the progress of the notification, including any problems with contacting recipients other than those with clotting disorders or PID. So is it right to understand from this that in terms of who's responsible for what, as it were, the panel's responsible for making these decisions about the 1% threshold, dividing products into high, medium and low risk, deciding on whether to adopt an umbrella approach or a bespoke individual approach to whether patients should be notified. But the organisation of the notification itself was to be done by the Health Protection Agency, the HPA.
Yes, that's right. And just to clarify, the panel's involvement, the decision about the umbrella approach didn't come from the panel. It came from the other groups who were present at that technical meeting before. But the panel supported that view, since it was felt to come from people who were intimately involved with the problem in hand.
And then just to understand how the individual risk assessments were done for that group of patients we looked at who might, in theory, cross the 1% threshold, but it would rather depend on how much they'd had. Yes. Is it right to understand that those individual risk calculations were done by the Health Protection Agency?
Yes, that's my understanding.
And then it's on this basis, is it, that the September 2004 notification of those with bleeding disorders and others took place?
Yes.
And did you have any concern about the fact that this notification was taking place almost 4 years after the VCJD IP had its first meeting in November 2000?
Yes, I think many of us felt that, and you know, since the panel was first formed, as I said earlier, there were always concerns about how long decisions were taking to be made, how long replies from the Department of Health or the CMO decisions were awaited, how long the consultations were taking, and I recall the first chairman, Professor Michael Banner, was particularly concerned about those issues, but there was little that the panel seemed to do, either through the chairman or individually, to try and speed these things up, but we did voice concerns about it.
Just in terms of how the notification should take place, you tell us in your witness statement, and we don't need to go to it, but it's at page 31, that you considered that for those who were at increased risk of VCJD, you would have expected information and advice to have been given in person by a healthcare professional expert in patient communication and familiar with the complexities of VCJD. Is that right?
Well, that's right, and that was based partly on our understanding of why the Haemophilia Doctors Organisation wanted to have this blanket approach. It was felt that I recall they said that they had very close relationships with the patients, and they were therefore able to communicate with them directly. And if that was the case, then that seemed to be better to be informed by someone you know than someone just beaming in and saying, "I've got some terrible news I'm going to give you." But it was a complex exercise, and the haemophilia doctors were haemophilia doctors. They weren't all experts in variant CJD, and I did go to speak to that group on a number of occasions to keep them informed about recent developments and updates, and we the unit and other groups offered support in providing more detailed expert advice should that be required. I don't, and I offered to help in that respect as well. Not because I'm an expert in communicating with patients, but I did know about variant CJD and felt I could help, but I don't recall being asked to do so.
Now, did you, the panel presumably understood that the plan was, in terms of the notification, that the initial sort of first communication with the patient would be by way of letter with information provided within it. The panel understood that?
Yes, yes.
But the expectation was, from your witness statement, looks like your expectation was that would be followed up in every case with a face-to-face consultation.
Yeah, well, the consultation should certainly be made available if the individuals wished it, and I imagine that many probably would.
Do you recall whether any special consideration was given to the notification of those who had already been infected by transfusion-transmitted infections, so that cohort of patients, both with bleeding disorders and other conditions, who had already been infected by their treatment, and whether or not special consideration should be given to that group in terms of the notification and the support should be available to them?
So I didn't quite catch the beginning of that, I'm sorry. Do you mean patients who've been exposed to other infectious agents?
Yes, so for example, those patients that had already contracted HIV or hepatitis C as a result of their treatment by blood and blood products.
I don't think that was discussed at that meeting. I mean, personally, I would feel that that would be appropriate. I would imagine that group and the groups who have been exposed to the highest VCJD risk should be the first group to be informed.
And your idea about a stage notification, was that so that there's sufficient time and resource from those that are charged with communicating with this patient group to meet with them and give them the support that they need?
Yes, it was partly out of practicality. It would be better to do this in a phase stage and have given the numbers concerned, you can't just create lots of expert advisors to provide advice, but there were enough to probably would have managed it had it been done in a phased approach.
And you also tell us in your statement, again, we don't need to go to it, but it's at page 82, that you felt that there was a need for a central group of individuals with a core brief capable of counselling, and then that had been identified as a as a need by the panel. What did you have in mind?
Well, people who are already involved in speaking to patients and communicating risk, and there are, for example, some of the staff in the unit who go and visit patients, the nurses, for example, and in the MRC unit, they have counsellors who are primarily involved in communicating risk to families with inherited forms of CJD, but their skills would be very easily transferable to a situation like this, and these people could be used to also to train others.
But you say that you were never contacted to fulfill that role. Was anyone else in this research and surveillance unit, to your knowledge, contacted to fulfill such a role?
Not to my knowledge, no.
And do you know, in fact, if any VCJD specialists were contacted?
I thought the Prion unit had been contacted, but Professor Collins would have been able to tell you about that, I'm afraid.
You also raise in your statement your concern, again, we don't need to go to it, but it's at page 82, that you had concerns about how, given how large and complex the notification process was, there was a lack of advanced planning. What specifically gave rise to those concerns?
Well, this was not at the panel meeting, this was at the technical group meeting before, and it just seemed to me that we all knew why we were at that meeting. We all knew there was going to be a decision made, and probably it would result in communication to large numbers of individuals, and it seemed to me that no thought had already been given as to how this would be carried out. And I don't think I was the only one at the meeting who got that impression either, and it was a matter of concern, and that's why I suggested that rather than having this approach trying to do everyone at once, it would be easier for all concerned if it was done in stages.
And having taken several years to get to this point, what do you think was the driver for pressing ahead in those circumstances where advanced planning perhaps wasn't as, the planning hadn't been done in the way that you would have expected?
I don't know. I think that perhaps this scenario had not occurred before, and the not enough thought had been given as to how it was actually going to be done, because I don't think such a large communication exercise had been undertaken, perhaps. But it seems to me that there was not much advanced planning, or at least none that was communicated to us anyway, and it seemed worrying.
And we heard evidence from Professor Collins last week that he had become concerned that the communications, as far as he understood them, to those that were in the first notification in December 2003, those that had received blood components, were told that they were at low risk of developing VCJD, and he thought that wasn't the case. Can you, first of all, would you agree with that those patients in that cohort were not at low risk?
I think the individuals in that cohort would not all have the same risk. Although this communication was going to everyone, not everyone was at the same risk. And it was possible, I think, to identify those who were at a much higher risk than others, and those individuals should have been informed accordingly, and the others perhaps could have been told that they were at low or lower risk than that. But that was the concern about the umbrella approach, is you tell everyone, but the question is, should you then tell everyone the same thing? And I don't think you should tell everyone the same thing, and it sounds that perhaps Professor Collins agreed with that. So
just in terms of the wording of the letters and so on that went out in the December 2003 notification, would that have been a matter for the Health Protection Agency to have finalised? What input would the panel have had in matters of those sort?
I don't think the panel had. I certainly cannot recall seeing any draft communications. I mean, I may be wrong in my recollection, but I don't recall that.
Can I then ask you just a question about what happened once the panel was disbanded in March 2013, so moving away now from notification? Yes. Can we look, please, at PHEN 40659? This is a meeting with the panel on 20th of September 2012. I can see on the second page that you send your apologies to this meeting, but I wanted to ask you about page 5, which I hope will be something that you will be familiar with. It says there, dissolution of the CJD incidents panel, and it sets out the future arrangements for future management of incidents. A comprehensive explanation of the way in which CJD incidents and risk management will be handled in the future following the dissolution of the panel on the 31st of March 2012 was provided to the panel the movement of incident management to local NHS trusts after 1st of April 2013, so there seems to be discrepancy in the years there, would be supported by the revision of the existing CJD incident and risk management guidance. This would bring the management of CJD in line with other unusual and rare diseases with HPA, PHE. PHE is Public Health England, is it?
Yes.
Continuing to provide a focus for advice. Once the HPA became PHE, it was anticipated that there would continue to be a CJD team, but this could not be guaranteed at this time. After 1st April 2013, the Advisory Committee on Dangerous Pathogens, Transmissible Spongiform Encephalopathy Risk Management Subgroup, chaired by Roland Salmon, would have any unusual or difficult cases referred to it and provide advice and revise the national guidance as necessary. This group may from time to time co-opt additional expertise, and CJDIP members agreed to continue to provide advice after the dissolution of the panel, but it was acknowledged that they would need to be kept up to date to enable them to do this. And then a question of indemnity is discussed. So the plan is, after the panel is disbanded, that it's to go, management of CJD is to go back to local level, effectively.
Yes.
With difficult cases being dealt with by the ACDP TSE.
Well, the TSE
Risk
group, the risk
management group.
The terminology of these things is beyond my
Was that a group you were
comprehension.
involved with? The risk,
Probably. Yes, no, I think I was the risk management subgroup.
and do you,
And then it all condensed into one group anyway. So there used to be a risk assessment subgroup and a risk management subgroup, but I think the risk assessment subgroup was taken over by SEAC, as it were, and then all the responsibilities go to SEAC. And so the risk management subgroup and then it became just the TSE subgroup, which made life easier. The TSE subgroup would advise on unusual or difficult cases, but not manage those cases. That's what happened.
and so there were unusual and difficult cases referred to the subgroup, were there?
I think from time to time there were, yes, that's right.
And what's your? I mean, I don't know if you have are able to give us a view about how that was working by the time you retired.
Which aspect of it?
Well,
sorry,
so that the fact that it's gone back to local level,
Yes.
and that then it's being difficult cases are being
Yes.
are being
Yes.
referred. Whether you have a view of whether you're able to give a view as
Yeah.
to how that was working
Yeah.
as a system.
Well, I think to start off with, it was a bit. I think it took time for the individual health. We call them health boards in Scotland, but the individual health groups in England, or the local health authorities, to get up to speed with doing this, and they had all the panel documents and advice, but actually dealing with it was more difficult. And I think there was a lot of, there were many inquiries coming to the subgroup just for individuals from those responsible who never had to take on the responsibility of dealing with it before, and they just wanted someone to bounce their plan off to see, this is what I was planning to do, is this okay? And those sorts of inquiries went not only to the TSE subgroup, but also to the CJD surveillance unit, to our epidemiologists, and also probably to the Prion unit, I imagine, too. So we all did our bit to try and help, and eventually it seems to be working, but there were still difficult cases, and I think there was a feeling of sort of loss of expertise generally.
I'm going to now ask you a couple of questions about testing for VCJD, and I just want to take you to a couple of documents. Can we start, please, by WITN 703 4013? This is a report co-authored by you.
Yes.
And it is dated December 2016, detection of prions in blood from patients with VCJD. And if we look at the abstract, please, about halfway down that paragraph, it starts by saying, we used the protein misfolding cyclic amplification, PMCA technique, to analyse blood samples from 14 cases of VCJD and 153 controls, including patients affected by SCJD and other neurodegenerative or neurological disorders, as well as healthy subjects. Our results show that PRP-SC could be detected with 100% sensitivity and specificity in blood samples from VCJD patients. Detection was possible in any of the blood fractions analysed and could be done with as little as a few microlitres of sample volume. The PRPSC concentration in blood was estimated to be 0.5 pg/ml. Our findings suggest that PMCA may be useful for pre-mortem, non-invasive diagnosis of VCJD and to identify prion contamination of the blood supply. Further studies are needed to validate the technique. So is it right to understand that this test could be used for asymptomatic patients where there's prionemia? In other words, where there's abnormal prions in the blood, but it's not yet prions have not yet invaded, if I can put it that way, the central nervous system, and the patient is asymptomatic.
This doesn't tell you that. I was involved with this group, Dr. Soto, and he is the one who pioneered this new technique, this protein amplification technique. And basically what it does is detects prion protein that's present at very low levels in a tissue or in a fluid like blood, and then it amplifies it by methods that you don't need to be concerned about, but it does amplify them to very high levels that could be then detected by conventional techniques. And by measuring the number of cycles of amplification, you can get an estimate of what you actually started with, which is the 0.5 femtomoles per mil. The blood sample, so I was involved in this, I've been involved with several of his papers. What I did as a neuropathologist was to provide samples of variant CJD tissue, brain tissue and spleen, for him to use this technique to get it worked up, to develop, to then use on blood, which was the ultimate goal and ultimate challenge, if you like. And the blood samples he used came from the CJD unit, but they were provided by my colleague, Professor Will. And as far as I know, I wasn't involved in the selection of these cases, and as far as I know, they all came from patients who were symptomatic at the time the blood sample was taken. So the idea of using it to detect asymptomatic infection is justifiable because you've proved you can do it using the samples from actual patients. The difficulty is then finding blood samples from asymptomatic patients, and are there any of these available in the UK or indeed in other countries? And I understand that there are, but I didn't have access to any of these.
And is this a test that's performed on whole blood?
Yes, it says, I think here, it can be performed on, as you've read out, different fractions of the blood, so it can be whole blood, it can be plasma, for example.
But you're not aware of what, we heard evidence from Professor Collins that there are such samples of fractions from asymptomatic patients who developed VCJD but at a time when they were asymptomatic, but you're not aware whether or not this test has been carried out on those samples.
I don't know if Professor Soto's groups carried it out, but there is another paper that you kindly provided to me from a group in France who used the same methodology, the PMCA, and they included in their tests some of these blood samples from asymptomatic patients, and they found that they could detect abnormal prions in the blood of these patients at least several months, or perhaps even a year, perhaps, before they became symptomatic. So it's the, I can't remember the name of the first author, but it's that paper that is the one that gives you the answer that you've been asking.
So this technique then is one that has the potential.
Yes, absolutely.
To become a blood assay for the blood services.
Yes, that's correct. I mean, I think there are two techniques, as I understand them, that are potentially usable. This one, and then there's Professor Collins' the direct assay technique, which uses a completely different methodology. I view the two as complementary, actually, because in many blood tests for other infectious agents, you need to have more than one assay, a screening assay and then a confirmatory assay, and I think probably these could be used together.
And do you know whether or not work is being done to progress the PMCA to a point where a commercial company might be interested in then scaling it up to potentially be able to be used by blood services?
I don't know the answer to that, I'm sorry.
And then picking up then on the evidence that we heard from Professor Collins about the DDR, I want to take you to the document we looked at with him, which is a minute of the ACDP TSE meeting in November 2016, and that's PHEN 302461. Sorry, it's September 2016, not November.
Yes.
And we can see that you were there attending, and we can see that Graham Jackson and Bernard Jollies were also invited experts.
Yes.
And then we looked at this last week, so I'm not going to take very long going through it, but just to orientate ourselves, if we look at page 8, we can see that Graham Jackson and Bernard Jollies from the MRC Prion unit and DGen respectively, this is para 6.1, and were welcome to the meeting, and then they give a presentation and there's a discussion about the DDA, the direct detection assay.
Yes.
And then we go to paragraph 6.9, please, on page 9, which I think is the point that you were just making. That the seemed to be agreement that there's the importance of using more than one test. In effect, an initial and a confirmatory test was raised. It was agreed that would be essential that two or more tests performed consistently over different sample populations. Yes. And then if we look further down to the page to 6.14, we see the conclusion of the meeting of the committee. It was concluded by the committee that ideally there should be a comparative study carried out using at least 2 different assays. This would allow for relative sensitivity and specificity between tests to be examined. The DDA was suggested as the initial screen, but this was not supported. And then there's a discussion about large-scale studies. Can you recall why the DDA was not supported at that meeting?
I think one of the questions around the direct, I do remember most of that meeting. It was a question of capacity partly, and also the issues of transferability of the methodology. Ideally, the methodology should be performed or capable of being performed in more than one laboratory or more than one unit, and that should be able to happen. And I seem to recall that there was some debate about how that could be best achieved. I'm not sure if anything happened subsequently about that, but it seemed to me that it should be doable in other places, and they should do it, and they should do both assays, whether one is a screening and one is a confirmatory or vice versa. It would be probably best to do it both ways, actually, I would have thought. I think there was also some question, how can I put this diplomatically, about conflicts of interest and private companies being involved, and I'm not exactly sure what that was, but there was something about, is it DGen?
Yes.
Yes, I think DGen would have to agree to it under certain conditions, and I'm not sure that was
That could
achievable.
be agreed. And certainly the inquiry's seen a lot of correspondence to and fro between various public bodies and DGen as to the circumstances in which matters could be progressed.
Yes.
But your view is that, putting those obviously very difficult issues to one side, the technology, if I can put it that way, or the science in relation to both the DDA and the PMCA,
yes.
could both potentially be used as screening tests for blood services if they could be developed.
Yes. I think both had great promise, and I think it's a matter of some considerable regret that this wasn't taken forward. Here we are.
I'm just now going to ask you, I've got two more topics to ask you on. Penultimate one is on post-mortem and tissue issues. I'm not sure that's a very good way to describe it, but can I ask you how long the Research and Surveillance Unit keep tissue specimens for?
It depends, and on the consent that is available from the relatives of the patients to allow us to do that. So when someone has a post-mortem performed, it's performed under two circumstances. Firstly, the relatives give consent for the post-mortem to be performed, and then they're asked separately, would they consent for tissue samples or organs to be retained for research use, and if so, they would be stored in the tissue bank of the National CJD Surveillance Unit, which is part of the Medical Research Council group of brain and tissue banks, and it has ethics approval for use, and so the tissue is available not just for us in the unit. Other researchers can apply for access to the tissue, and we've provided tissue that's been used in research projects across the world and has actually been, very widely used, and I've been very glad to see that happen. However, if that isn't obtained, the tissue is retained for the time until the diagnosis is made and the relatives have been informed, and then the tissue is either it can be returned and be cremated with the rest of the body, or it can be cremated separately if that's the case, or it can be disposed of respectively through the hospital route. The second way a post-mortem can be performed is a medical legal post-mortem, which is a coroner's case in England or a procurator fiscal in Scotland. And my understanding in those circumstances, the relatives, the body at that time becomes the property, as it were, of the coroner or the procurator fiscal who instructs the post-mortem performed. We normally would then ask the fiscal or the coroner to ask the relatives, or if we could ask the relatives if they would agree to donate the tissue samples for research afterwards. Some do, others don't, and that decision is entirely up to them. But if they do, then we keep them, and if we keep them indefinitely or until the tissue has all been used. And my experience of speaking to relatives who've visited the unit or the others, they often ask what type of projects have been used, and we can provide them with that information, and they seem to be interested. So some are, but some are not less interested, but they just don't want to know, and that's fine as well. So it depends on the consent, but if we do get consent, they're kept for as long as they can be used.
And are any tissues or indeed blood samples kept under the auspices of the TMER?
No, the tissue collections I'm referring to are autopsy samples. So any samples from living patients, blood samples or CSF samples, these are not my concern. These are dealt with by the clinicians in the unit, which is Professor Will or Professor Knight. And likewise the CSF samples.
The inquiry has sent you an application that was made to the MRC for funds for MRI imaging in AIDS research.
Yes.
A proposal from the Edinburgh University and City Hospital in Edinburgh to compare MRI observations in HIV patients with histology at post-mortem, and we can go to it if we need to, but I wonder if I can ask the question without looking at the document. Now, that proposal involves your colleagues, Professor Will and Professor Bell. Do you know whether funding was granted for that piece of work?
I don't think Professor Will was involved with that. But certainly Professor Bell was. She's also a neuropathologist. My understanding was that it was granted. It was part of. It was a combined study from, I think, London, King's College, I think Oxford University and Edinburgh, and the idea that there would be joint activity, parallel activity going on in all three sites. So when I went to Edinburgh in 1990, that project was up and running, and Professor Bell was performing these autopsies when consent was given and collecting tissue samples, and the brain was being imaged, and that was up and running. So I assumed from that it had been funded, but I never actually saw a letter of award from the MRC. We looked at the study you did. You looked at the study this morning that you did on a cohort of AIDS patients. That's correct.
With haemophilia to look for prion disease.
Yes.
Were those patients were part of this study?
That's correct. That cohort of individuals where consent for research had been granted was then used to answer the question which was never thought of at the time of the original application, was could any of these patients be suffering from a prion disease? And
the reason that you could carry out the research for prion disease was, for the reasons you've given earlier, was it that consent had been given by relatives to do medical research, full stop?
Yes, that's right. And the project also had received ethics approval from the Regional Ethics Committee.
Did you carry out any examinations yourself on this group of HIV patients under the HIV study arm of the research?
Yes, I did. I did. Professor Bell and I think, were the only pathologists in Edinburgh who carried out those so-called high-risk autopsies. High risk because it carries a high risk of infection to the one performing the autopsy, unless you're careful not to cut yourself or any exposure-related incidents. So we did that, and having established the methodology for doing that, we could use it also for CJD autopsies. So I did that. I mean, Professor Bell was the lead on that, and I supported her in that project.
And can you recall what the findings were of that study on the patients, the HIV patients? Because was it to compare MRI imaging with histopathological tissue?
I wasn't really involved in the imaging part of it. I just performed the autopsies, really. So I wasn't involved in the analysis of that. But I know there were some very interesting findings emerged from the involvement of the brain in these groups of patients, and also comparing the disease that occurred in haemophilia patients compared with the disease as it occurred in other at-risk groups. And of course, Edinburgh had this large group of intravenous drug abusers who were also widely infected with HIV, and so that was a very interesting comparison to make.
You mentioned the tissue bank that's held as part of the MRC brain and tissue banks.
Yes.
In that application, the MRC application, there is a letter and some information that refers to a brain bank store of the brains of those who had died of AIDS in Edinburgh. Was that ever established? If so, is it a different thing or the same thing as the tissue bank?
It was established, and that was a different thing. The HIV project was set up and I think probably funded before I arrived in Edinburgh. It was up and running, and I supported it, but I wasn't involved in setting it up. But the CJD project was a separate thing, and we set that up with funding initially from the Department of Health, and then we obtained some MRC funding for that. And then after that, the MRC decided that collecting samples of brain tissue for a whole range of diseases was a good thing to do, so it would support research into all forms of dementia. And I became they decided they would set up a network of brain banks in various centres across the country. I became the director of the MRC Brain Bank Network, and we made sure that the brain banks were all operating to highest standards of ethics, efficiency, and were used widely as possible for research.
And does there remain a brain bank in Edinburgh?
Yes, there is a brain bank in Edinburgh. Is my colleague, Professor Colin Smith, who's now the director of the CJD unit. He's also the director of that brain bank. But the brain bank now includes a whole range of other neurological diseases: Alzheimer's disease, motor neuron disease, Parkinson's disease, and CJD, and research going on in one of these diseases also often informs research on the others. So it's been a really valuable and widely used resource for researchers.
And lastly, I'm going to ask you some questions about prevalence of VCJD and what we know or think about what may happen in the future in terms of numbers. I'm going to start, I think, with your study you co-authored, colloquially known as the Appendix 3 study, in 2020, WITN 703-4009. So we can see the first couple of sentences sets out the background, and the second sentence says 2 previous appendectomy sample surveys, Appendix 1 and 2, estimated the prevalence of an abnormal prion protein in the British population exposed to BSE to be 237 per million and 493 per million, respectively. Now, just pausing there, can you just explain to us what that finding actually means?
Okay, well, After variant CJD was identified, we tried to find out as much about it as possible, and so when postmortems were performed, we sampled a whole range of tissue samples to see if the prion protein was there, because we thought the oral route of transmission was the most likely, and therefore how did the agent get from the gut to the brain? And we also knew from animal models that the spleen and other lymphoid tissues were often involved. We'd actually looked for that, or I'd looked for that, in other cases of acquired CJD, including in growth hormone recipients, which perhaps surprisingly doesn't have that pattern of involvement, but it did occur in variant CJD. It was present in the tonsil, present in the appendix. And my colleague David Hilton in Plymouth, who's a neuropathologist, referred a case to me of variant CJD in whom the appendix had been removed because of appendicitis several years before the patient died, and he decided he should review this to see if it contained any prion protein, and it did. So that established a proof of principle, is that we could detect abnormal prion protein by immunostaining using an antibody to the prion protein in these tissues, and that might then allow us to estimate how many people were incubating or asymptomatically infected with variant CJD. So that study was set up. It was funded initially by the MRC. There was an MRC advisory committee on how many cases we needed to look at, what statistical tests we need to do. So we did all that, and the study received ethical approval on the grounds that it was anonymized and unlinked. So we could look at so many hundreds or thousands of cases, but we couldn't know where they came from. And that was slightly problematic, because if we did find a positive case, should we not do something about that? But we couldn't because of the ethics. So there we are. That was one of the difficulties about that study. However, they were done, and slightly surprisingly, the numbers were perhaps higher than many people expected. And then after the Appendix 1 study, there were all sorts of questions put forward. Was this a non-specific finding? Were we actually just looking at artifactual staining? Could we do it better or bigger? So we did it bigger, and the numbers then were even higher than in the first time. And in the meantime, we had this case of the asymptomatic infection in the transfusion recipient, where we used the same methodology to detect PRP in the spleen and in lymph nodes, and then we were able to transmit the infectivity in that spleen. So that proved that the staining methodology we were using was actually able to detect infectivity in that tissue, and so it was reasonable to assume that the same was being demonstrated in these appendices. The Appendix 3 survey, as it says here, was recommended to measure abnormal PRP in population groups thought to have been unexposed to BSE, in a way to rule out this non-specific staining phenomenon. And what happened in Appendix 3 was that there were 7 cases identified, 2 of which were in the so-called pre-BSE era, and 5 of which were in the so-called post-BSE era. That can be interpreted in a variety of ways, that either that BSE exposure actually occurred earlier than was thought, which is quite a reasonable possibility, and that it continued into the late 1990s. But these are the figures, and the findings are there. We think that they do represent asymptomatic infection. If that's the case, why have there not been more cases of variant CJD? We looked at the genotypes of these groups, and we found that all genotypes were present, MV, and VV, interestingly. And I think this just reinforces the need for caution in predicting what the future of variant CJD will be in the UK.
So to understand about the Appendix 1 and Appendix 2, and just for the transcript and those that are listening, Appendix 1 is March 2004.
Yes.
And the reference for that is NHBT 006 3957_002. And Appendix 2 is October 2013, and that's PRIU 5069. So they were detecting abnormal prion protein in the population in the BSE years.
Yes.
During the period where it was thought that the population were being exposed to BSE. And the Appendix 3 looks at the prevalence in the British population before the BSE years and after the BSE years, in those two different periods. And you still find within the population some cases, albeit lower than within the BSE period, of positive positive samples.
Yes, interestingly, in the pre-BSE group there were 2 positive cases, but they were in appendixes that were removed 1977 or afterwards, and not any earlier than that. So they weren't distributed throughout the whole time scale that we looked at, but only at the very latter part of it. And likewise, the opposite with the post-BSE, it was only in the immediate post-BSE period that the more recent ones were negative. So I think that can be interpreted in a number of ways, but one way is that probably the exposure to BSE was longer than anticipated.
So that's one explanation, and as you say, the temporal factors would lead support to that analysis of the results. The other that you put forward here is that there is just a low prevalence of abnormal prions in appendices in the population, not related to BSE, and if that's a possibility, what does that mean for prevalence study, the Appendix 1 and Appendix 2, for example?
I personally don't think, that is a possible interpretation. It's not one that I favour, but it's I guess what it's trying to say is that perhaps exposure to prions is occurring more widely than we thought, or from different sources, and low levels can be there, and they don't, because they may not all be related to BSE. There may be some other factors involved. I personally don't favour that hypothesis, but it was included as a possibility, but not my favoured possibility.
So you're choosing between those options. You're firmly, are you, in favour of the?
Yeah, I think so. We were very careful about what we designated as a positive result or not in these studies, and the work we've done on the asymptomatic infection cases, and also there's a large literature of work done in animals with prion diseases, in sheep with scrapie, and in deer with this disease, chronic wasting disease. And in both these diseases, the lymphoid tissues are involved, and they actually used analysis of lymphoid tissues to predict if these animals are going to develop the disease, and it correlates very well. So I think from animal models and from the admittedly very limited human experience with VCJD, a positive result does equate to infectivity.
Now, we know from the documents that the inquiry has received and the evidence the inquiry has received that there were some recipients of plasma products who in 2013 were denotified of their at-risk of VCJD status because the view was taken, initially the period for being at risk VCJD from receipt of plasma products was, I believe, 1980 to the end of the century. And then there was a risk assessment, and it was thought, well, actually between 1980 and 1989, there doesn't appear to be any exposure. So those patients who had only received plasma products in that 1980 to 1989 period were then denotified. Does this study suggest that that conclusion should be relooked at?
That's a very good question. I think that it could be reviewed, but fortunately the numbers are very, very small, and it still may not be relevant, because even if there had been some possibility of infectivity, it would probably be below the threshold for notification.
So just looking at what we know now in terms of prevalence, and the Appendix 1 and Appendix 2 giving fairly high positive samples per million, but on the other hand, there being very few cases of VCJD. What is your view on prevalence of VCJD in the UK at the moment? Do we have enough information? Should there be more prevalence studies? Should there be more modelling?
I think the best thing would have been if the technology for the 2 blood tests had gone ahead, and then you could do an anonymised prevalence study in the population, as was done with other viruses like hepatitis and HIV, to see how widespread the problem was. And that would no doubt help resolve this, but that hasn't happened, so we're left in this difficult position of knowing what to do about it. There have been no more cases of variant CJD since the last patient died in 2016, and the predictions, the last paper by Azra Ghani and her colleague was in 2010. I think the uncertainty in the tail of the epidemic, I think that work could be revisited and updated to see how things look. Taking into account these findings, I think we're left with the situation that perhaps the infectivity that's there may not always end in a neurological disease. But it doesn't mean to say that these individuals are not infected.
And I just have one more document I want to take you to before I finish my questions, and we have a break to allow others to suggest questions to me. And it's WITN 703 4019. And this is a paper that is not co-authored by you. It's CJD, a systematic review of global incidence, prevalence, infectivity, and incubation. And second sentence in that bold paragraph at the top. In this review, we sought evidence to understand the current iatrogenic risk of CJD to public health. And I should pause and just say this is a January 2020 paper. By examining global evidence on all forms of CJD, including clinical incidence and prevalence of subclinical disease, we found that although CJD, particularly iatrogenic CJD, is rare, the incidence of sporadic CJD is increasing. Incubation periods as long as 40 years have been observed, and all genotypes have now been shown to be susceptible to CJD. Clinicians and surveillance programs should maintain awareness of CJD to mitigate future incidences of its transmission. Awareness is particularly relevant for sporadic CJD, which occurs in older people in whom clinical presentation could resemble rapidly developing dementia. And then if we could turn please to page 4. along the left-hand column, that first full paragraph there, confirmation of CJD from autopsy or brain biopsy is required to obtain a definitive SCJD diagnosis. However, autopsy is not routinely done on patients with SCJD. Only about 50% of all deceased patients in the UK referred to the NCJD RSU are autopsied, and this rate is potentially decreasing. The most recent case of VCJD appeared on clinical presentation and neuroimaging to be SCJD. But as the age of the patient was atypically young, 36 years, a neuropathological examination after their death in February 2016 confirmed VCJD, despite the fact that the patient did not exhibit clinical and epidemiological diagnostic signs for a probable or possible VCJD. On the basis of this VCJD case, pathological examination of every SCJD case would be necessary to know the true numbers of patients with autopsy-proven SCJD and VCJD. Given this scenario, an alternative possible explanation for the increasing numbers of SCJD cases in the UK over the past 20 years could be that the altered incubation and clinical presentation of acquired CJD, VCJD or ICJD appeared to mimic SCJD or another neurological condition, as has been shown in murine models. Now, you've already given us some evidence in relation to this latest case.
Yes.
But just looking at it from the perspective of what it tells us about prevalence and the fact that sporadic CJD cases are increasing, autopsy rates for such cases are decreasing, and we have cases like this last one which look, until you have an autopsy, as if it's SCJD, but in fact turns out to be VCJD. Where does that leave us?
Well, I think it's a very complicated situation. I think there are other explanations as to why sporadic CJD might be increasing, including just better surveillance, and this has been seen by there have been publications looking at this in a number of countries using comparable methodology for sporadic CJD, just saying that the intensity of surveillance identifies more cases, the better at diagnosing that. Second argument, which I think is also put forward elsewhere in this paper, is that the population is aging and sporadic CJD occurs most often in the 7th decade of life. Therefore, the more individuals you have who are reaching that decade, the more likely there is to be sporadic CJD. And the third possibility is exactly what they're saying here, that actually some of the variant CJD infections, particularly in the non-MM genotypes, might actually manifest as something more like sporadic CJD rather than variant CJD. And unless you're performing an autopsy, you will never know really if that's the case or not. Another approach to answer that question actually would be using the blood assays that I keep coming back to, because the PMCA technique works very well at detecting variant CJD. It can work on sporadic CJD. It's more difficult to set that up to achieve it. But the advantage that technique has is that the prion protein that's amplified, you can then do another technique called a Western blot on it, because you've got enough material to do it with, and you can tell whether it has the banding pattern of variant or the banding pattern of sporadic. So that's another reason why investing in the blood testing technology would answer the question without necessarily having to do an autopsy to prove it. And as a pathologist, I shouldn't be saying that, but that in fact is the case.
And would there be a case in light of the factors that are exhibited in this case for those with suspected sporadic CJD to be investigated during their lifetime in the same way that those with VCJD are investigated, to consider whether or not they've either had or received a blood transfusion, and so that tracing can be done to see whether there are implicated products.
Well, my understanding is that in the TMER study, sporadic CJD cases are also looked at, and I think recently we published a paper where we identified 2 cases of sporadic CJD in recipients of UK plasmid product. So I think that work is actually probably being done already. The question of whether sporadic CJD is transmissible by blood has been asked on a number of occasions in different countries. There's never been any good evidence that it can be, but that's not a reason. I mean, things in this country may well be different, and I think that sort of work should continue.
And that paper that was published in relation to the 2 patients, I think, with sporadic CJD, the concern was they had been recipients of plasma products. Is that correct? And so the question was, well, had they got the SCJD via the plasma products?
Well, they certainly didn't have variant CJD, because I know, because we actually, that work was done before I retired, and we interrogated that possibility very carefully, and they had all the classical phenotype of sporadic CJD at autopsy as well.
And the conclusion of that paper was that that a link couldn't be made. Was that right, between the receipt of plasma products and the development of SCJD?
That's correct, but I think we also said that this phenomenon was inexplicable at present, and so that it should be left open as a possibility for future research.
So those are the questions that I had for Professor Ironside. Could we have a break now to allow call participants and their legal representatives to put questions to me that they think I should ask Professor Ironside?
Yes, let me just explain, Professor. There are a number of core participants who have been watching this online, as I said, and some also whose lawyers are here. They have a right to ask questions of you through counsel. And in order to exercise that right, plainly they need to tell counsel what questions they would like asked. I don't know how many there will be. There may be a few, there may be many, so I can't predict that. But we do need to give some time, so half an hour, would that be long enough, do you think?
Yes, I think so.
So we'll take half an hour and come back, let's say at 20 to 4.
That's fine, yeah. Thank you.